Okay, this is a continuation of the eye assessment. We ended on the otoscopic examination when we began to inspect the tympanic membrane. So we're going to go ahead and continue where we were at. We were using the otoscope here with the light, using it to be able to inspect and assess the tympanic membrane. So what we're looking for basically are different landmarks, such as the umbo, which is at the center of the tympanic membrane, and then the handle of the malleus, and we are also looking at the light reflection of the speculum when we're assessing. So basically what we're looking for is a translucent pearly gray color of the tympanic membrane that is normal. There is a picture here that provides a good picture of it here. So also we're looking at the contour of the tympanic membrane. It shouldn't be bulging and it shouldn't be retracted. It should be conical, and its concavity should be at the umbo. So if you see that it's bulging, it should be a little more conical. You'll see that the light is a little bit distorted. Normally the light would be triangular in shape, so that light would look different in a bulging tympanic membrane. You would not be able to see the landmarks such as the handle of the malleus and the umbo at the center of it. If it's retracted, however, and inward, towards the middle ear, then you should see that it's more concave, and it's all the opposite of a bulging tympanic membrane, because the landmarks are a little more accentuated in this type of tympanic membrane, and the light is also distorted as well. So there should be no perforations in the tympanic membrane. There is an annulus surrounding it that should be a little whitish in color all around it. So that's the tympanic membrane. Now let's move forward to the assessment of its mobility. Now for that you would need a pneumatic attachment to where you could apply positive and negative pressure into the ear. Now it needs to be well sealed whenever you place it in. And the thing about that is when you're applying positive pressure, it should move the membrane in towards the middle ear. And when you apply negative pressure, it should bring it out. And you should be able to see that, and also see this distortion of light when you do that whenever you're applying the pressure. So that's how you assess the mobility of the tympanic membrane. Now, if it does not move and it kind of stays in the same place, then that could be indicative of either a perforation, or maybe of acute otitis media, or maybe otitis media with an effusion. So that would warrant further assessment. So that completes the portion of the otoscopic examination. Now we're going to move forward to the hearing assessment. So the hearing is determined by the cranial nerve 8, which transmits those signals to the brain for interpretation. So there are 4 ways to evaluate hearing. And first and foremost, whenever you're speaking to a patient and you're getting the history and physical, for example, and you're asking questions, one of the things you really want to look for is the patient kind of cupping his ear because maybe he doesn't hear you very well, or is he tilting towards you because he doesn't hear you? Also his speech, is he talking in a monotonous tone, or does he have like erratic volume changes when he speaks? All of these things would be indicative of a possible hearing loss. So watch out for that. Now the second way to assess hearing would whispering would be a test with whispering included. Now when we do this, what would happen would be that I would ask the patient to go ahead and take his finger and put it in his opposite ear, the one that will not be tested, and make sure that he cannot hear very well from that side. And now I'm going to go ahead and whisper 3 different numbers, letters of the alphabet, whatever you want, but it's got to be in a random form. So for example, I'm gonna go ahead and whisper it in his ear on this side, okay? And then I'm gonna ask him to repeat what I just said. Now you want to stand about 1 to 2 feet away, out of the line of vision, so that they don't attempt to see what or lip read. So now we're gonna try this.
T9.
Okay, so we would go ahead and repeat that on the opposite side as well, but he got all 3 right. So we want to make sure that if you give them 6 different numbers and letters, at least 3 out of the 6 are right. Now, we're going to go ahead and move forward with the Weber test. Now, the Weber test uses something called a tuning fork. Now, we're going to go ahead and use just a simple kitchen fork because we do not have a tuning fork right now. So what we do is, in the Weber test, we go ahead and ring the tuning fork, and then we're going to position it right in the center of the patient's head. And what we're going to do is ask them in which side do they hear the sound. Now this is testing bone conduction. So if he was to tell me that he hears the sound on both sides, then that would be a normal finding, because that would mean that the bone conducts to both sides of the ear and he hears them on both sides. Now, if he was to say that there is laterality in there, that he only hears it on one side, then either one of 2 things. Before I go ahead and send him off to get a hearing screen, I would go ahead and test the reliability. By doing that, I would go ahead and tell him to close the ear off with a finger again on one ear, and then I would go ahead and ring the tuning fork, place it on there again, and I'd ask him, on which side do you hear the sound better? Now, normally you would hear it better on the side where you have occluded the ear. And if he does hear it on the side where it is occluded, then the test was unreliable and therefore inaccurate. So moving forward to the Rhine test. Now the Rhine test is also a hearing test that we use a little bit differently though. Still using the tuning fork, we go ahead and ring the tuning fork, and instead of placing it up on the midline of the head, we go ahead and place it right on the mastoid bone. Now, when we place it on the mastoid bone, we are, again, testing bone conduction, and we want to time it to see how long he hears it for. As soon as he stops hearing it, we go ahead and record that finding, and then what we do is we go ahead and ring the tuning fork one more time, and then we're going to place it here about 1 to 2 centimeters from the auditory canal, and then we're going to time to see how long it takes for him to stop hearing the sound once again. Now normally this test bone conduction versus air conduction, and normally you should hear air conduction twice as long as bone conduction. So if he heard, when I put it up to his mastoid bone, if you've heard it for about 15 seconds, then you should hear it in the auditory canal for at least 30 seconds. Now that would be a normal finding. So let's go ahead and move forward to the nose, nasal cavity, and sinuses assessment. Let's go ahead and begin with the external nose. Now when we look at the external nose, we're talking about this area here. Now we want to check the shape, the size, and the color of it, making sure that it is the same color as the facial skin, and that there is no protuberant lesions, that there is no lack of symmetry anywhere, anything that is abnormal. So as we can see here, it looks like both sides are pretty symmetrical. It looks like the color looks okay. I don't see any exudate coming out. I don't see any lesions, nodules. I don't see anything abnormal here. So next we would check the nares. Now, like I said before, when we check the nares, we go ahead and ask him to move his head back just a little bit so we can see it a little more. Now we take our nasal speculum, and we go ahead and check the nose, And we're looking for any discharge, we're looking for any flaring of the nares, any narrowing of the nares. So in this case, I don't see anything like that. If you were to see discharge, we would want to note the character, the amount, the color, and if it's coming from one side of the nose or bilaterally. We're going to go ahead and stop here, and we're going to continue this assessment on the next video.